Boa tarde. Thank you very much for the opportunity to speak with you today. I want to congratulate and thank the Portuguese Association. This has been a wonderful meeting, and it was very kind of you to invite me to give the final words, which is a humbling challenge. And what I'd like to do in the next 25 minutes is share with you some of what I've learned in sitting in on more than 4,000 patient consultations with more than 400 family doctors in more than 70 countries. You know, we began our conference this week with Dr. Joana Carneiro, and she taught us what it meant to be a conductor of an orchestra, which is what I think we are as family doctors. And that means that we need to know each of the instruments and have a pretty good ability to play each one, but more importantly, is we need to understand the purpose of it all. Why do we have these instruments? How do they come together? How can we make them in harmony? We heard also from Professor Michael Kidd, the current World Wonka president, about some of the innovations that are happening around the world through Wonka, activities with the World Health Organization, rural health, mental health initiatives, work health, educational projects like the certification program just starting in Shanghai, and the young family doctor movement, which began here in Europe. Vasco da Gama is a leader in the world, and I know you'll continue to provide great leadership for the rest of the world as their regions get moving forward. So now what I've got to do is pull up my slide, which I hope that does it. Yeah, we've got it. Thanks. So since I have the final words, I decided to treat you as I would treat an audience of other specialists. I'm going to use just a few words, and I'm going to keep them small so that they can understand it too. And the first word I'm going to start with is trust, because I think a fundamental challenge for all of us in healthcare, but especially for family doctors, is to take the tasks that we do and turn it into trust. The tasks include the treatments we give people, the advice, and so on. And trust for me has 5 elements. It takes time to build trust. You have to be reliable. When I need my doctor, I need my doctor, not the nurse, not the receptionist, not the physio. We have to have unity of purpose. We have to all be lined up doing the same, toward the same goal, helping our patients achieve their health goals. We have to do it with some skill, and we need to do it with transparency. And what I mean by that is I think a big mistake that many of us make is that we do not trust our patients. We build walls between us and them. Have you ever tried to call and talk to a doctor? You have to get through the receptionist, the nurse, the medical assistant, the accountant sometimes. It's quite a challenge. Our dilemma today is we're getting ourselves so separated from patients that at times we're forgetting who it is that we're at work for. And I think in the future, those of us that will be most successful will figure out how to tear down those walls. And the tasks that we do come out of our science. We're supposed to do things that are scientifically based. Well, let's talk a bit about our science. What drives our behavior as clinicians is evidence. And the evidence comes from, I don't know if that's going to show much, the evidence comes from the literature, and we take that evidence and we put it into different kinds of guidelines or practice recommendations. And then many times our governments or insurance plans then will take those guidelines and make performance measurements, and they will hold us accountable for achieving what the guidelines said. But the first question is, how good is the evidence? And as someone who has spent most of my academic career doing decision science, the technical term I would use to describe our science is that it sucks. And the reason that it sucks is you've got the wrong people doing the wrong research on the wrong patients in the wrong setting, coming up with the wrong answer. And I like to use this study by John Ioannidis, who's a Greek-American internist, health services researcher. And what he did is he looked at the world's best medical studies. These were the ones that were quoted or cited more than 1,000 times in later studies as proof of their influence. And what he found was that only 44% of them actually had their conclusions or findings validated or replicated by later research. And so when a medical student or a trainee asks me, what should we do? Should we do this or should we do that? I say, well, we'll do better to flip a coin, which gives 50% accuracy, than to go to the world's best medical literature. And the reason that I say that we have the wrong people doing the wrong research is that healthcare, even in my own country, is predominantly a primary care phenomenon. So if you follow 1,000 Americans over the course of a month, 750 of them develop symptoms. They have a heart attack, they get depressed, they have respiratory infection. 250 go to primary care, their family doctor. 9 end up going to a community hospital for hospitalization. 5 are sent to a community-based consultant, and less than 1 out of 1,000 goes to the academic health center. Yet who does the research? The people at the academic health center. And I'm with the university, and if my endocrinologist is seeing patients more than 1 day a week, he's breaking a sweat. He's not used to that. He's spending his time doing other important things. He's doing research and teaching and administration, but he's not on the front lines actually taking care of the diseases that he likes to do research on. That's us. And in fact, when you look at what we do, it is amazingly complex. In a typical encounter, we will discuss between 3 and 8 problems with the patient. And I'm not talking about atrial fibrillation versus coronary artery disease versus congestive heart failure. I'm talking brain, heart, foot, intestine. And another way to say this is if you look at the top 5 diagnoses, ICD diagnoses, for any specialist, most of the time you'll capture 90% of what they've seen. So for a cardiologist, it's 401.1 hypertension, it's 272.4 dyslipidemia, and so on. If you look at the top 25 diagnoses of a family doctor, you've only captured 60% of what we see. And another way to say this is to look at the complexity of any one encounter, and this was a study that did that. And what was shown was that the total complexity, using a complexity rating scale, was highest between family doctors compared then to cardiologists and psychiatrists. And in fact, it was even more dramatic if you looked at the amount of time that the family doctor did to have this complexity addressed sufficiently. So we were almost a third more complex per unit time than cardiology or psychiatry. So one example that I often use, because I do a fair bit of work around decision science and guidelines in diabetes, is that if you look at hemoglobin A1C, which we commonly use as a measurement to measure how good a job we're doing with our patient population of diabetics, nobody had ever really studied whether the guidelines, which had recommended for 20 years to keep the hemoglobin A1C less than 7, nobody had ever looked at that. And that finally was looked at a few years ago. And 3 large studies, 1 Australian, 2 US, showed that in fact you had a higher death rate if your hemoglobin A1C was less than 7 as a type 2 diabetic. So I was at a meeting in Santiago, Chile when these results were being revealed, and I was sitting on a panel with 5 international diabetes experts, and they spoke before me, and the name of the panel was basically, why cannot we get primary care doctors to do what they're supposed to do with diabetes? And so the first thing I said was, when it came my time to speak, have you seen these studies? And they all kind of looked down at the table. And I said, please explain these findings to me. And one of the experts said, well, you have to understand, they were not dying of their blood glucose, they were dying of heart disease and stroke because they had high blood pressure and high cholesterol. And I said, yes, that's 91% of type 2 diabetes patients. So if you're only looking at the 30-year-old who's just been diagnosed with type 2 diabetes and has no other comorbidities, and whose mother says, go to the university because that's where the experts are, then maybe your guideline of 7 or less works. But for the vast majority of patients, it doesn't work. Because it may surprise you, death is actually an important outcome to somebody with diabetes. And if you take, and I did this presentation a year ago before the European Commission, the health ministers came together to look at aging and healthcare for the aging and the issue of adherence or compliance. And the title of that conference was basically, why can't we get old people to do what they're supposed to do in terms of health care so we keep our costs down? And I said, well, if all the old people in Europe had followed the European Diabetes Society guidelines, you would have killed off 39,000 more people with diabetes. Now, maybe that's what you want as ministers of health. It lowers your budget. And, of course, they were all a bit red-faced looking down at the table. But here truly is our challenge if we're to develop our science. 40% of the new presentations that our patients come in with, a new complaint or concern, 40% of those will not fit any criteria of any known diagnostic classification system. So how do you study that? How do you develop guidelines? How do you develop performance measures? We have built a house of cards, and it's going to collapse on itself. 40% of our patients have multiple comorbid conditions. Half of the patients over 65 had 3 or more conditions, and 20% have 5 or more. And yet the guidelines are always designed for a patient who has no other problem except the index condition. And the study always has exclusionary criteria that only allow for one problem, but that's not reality. So I think the new science is actually going to be generated by us. We're going to move from academic health centers to practice-based research networks. We're going to use techniques like geomapping to actually plot using households where hotspots are with certain kinds of conditions. We're going to move from randomized controlled trials that are so expensive and answer such narrow questions to quality improvement projects that involve tens of thousands, hundreds of thousands, and allow us to draw conclusions. We're going to move from reductive to integrative, from univariate to multivariate. We're going to be shifting our basic science in primary care from epidemiology to complexity and systems theory. We're going to move from short-term studies. I mean, have you ever met a patient that you put on a medication and say, I only want you to take this for 12 weeks? Well, that's what all the drug trials are built on, a 12-week placebo-controlled, double-blind, randomized crossover trial. Who cares? You know, give me something you're going to be on for 20 years. Then that's a study. And we're going to move from expert outcomes in terms of what experts have thought was important to what patients think is important. And so what I always say about measurement, and I don't have anything against measuring our performance as physicians, but what I want you to do is to make sure that you're measuring what we care about. You better value what you measure because what you measure will be valued. So what are the outcomes that matter to patients? Death, disability or dysfunction, discomfort, distress, and I had to be alliterative, so I'll use dollars, but it could be euros or pesos or whatever. And here's some numbers, if you want numbers, that I would ask policymakers to think about. One is that the probability that a healthcare worker will make at least one mistake in a career is 1.0, 100% likelihood. And the probability that each patient will die is 1.0, 100% likelihood. Those are the boundaries within which we operate, and it's a challenge for us. So, we do things to people, we do stuff to people that sometimes hurt them. Let me offer a radical idea. Perhaps we should do less stuff. We hand over the patient many, many times within our own practices to the nurse, to the diabetes educator, to the physio, to whomever. But every time we hand that patient off, we increase the error rate by 10 to 12%. Perhaps we should hand off the patient less. So that gets me into team. Now, none of us could imagine practicing without a team, and we all like to talk almost poetically about how wonderful our teams are. And I have met some great teams. Here was a team, a doctor, a nurse, and I won't tell you who's who in the picture, that do home visits together. And it was a terrific program. It helped to keep older people in their homes many times. It was a real honor to be able to go out there with them. Here's a team in front of a consultorio in Cuba, in Havana. They do a great job with very limited resources, getting excellent outcomes. But I've also visited in Santiago, Chile, and watched on a Saturday morning 10 health units come together from different parts of the city, and for 3 hours, the receptionists would stand up and they'd talk about their projects, and the nurses, and the pharmacists, and so on. And at the end of the morning, I raised my hand, I said, where are the family doctors? Oh, they don't come to this. I said, the family doctors don't come to this meeting where people are talking about learning from each other? That's terrible, but I'm going to have to go talk to them. So the next day, I did. And I met with several young family doctors. I said, why don't you go to the Saturday morning meetings? They said, I don't have the time. I said, what my job consists of right now is I spend all day seeing too many people, filling out forms, doing paperwork, signing off on the things that the other people did, and they go home at 5 o'clock and I'm still here at 7 o'clock at night filling out paper. That's not a team. That is not a functional team. But if you allow the members of the team to each define what they do without a negotiation as to the whole team deciding what should happen, you're never going to get anywhere. And so teams can be toxic. Now, the other key part of a team is deciding what you're trying to accomplish. So you could look at this photo. This was taken in Aveiro, and it's a Vasco da Gama leadership group. You could either say this is a very dysfunctional team if they were all trying to jump at the same time. But if this was a team that was doing a wave in synchrony, it might be perfect. Why do I say that? Because you have to remember that the point of a team is to meet the needs of the patients, not the needs of the members of the team. And we spend so much time trying to take care of the team that we don't spend enough time taking care of the patient. Tools. The thing I love about family doctors as I travel the world is we're very practical. We can use the most basic of tools. This is Dr. Kobranov from Western Tajikistan. Amazing doctor. Here's Dr. Kaira in Zimbabwe, one of the poorest countries on earth. One doctor for every 100,000 people. And he was excitedly telling us about not only the electrocardiogram machine he had just acquired, but also an ultrasound machine he had just received. He does cesarean deliveries, also another amazing doctor. Here's a family doctor in rural United States doing a cesarean. We will use the tools that benefit our patients, and we should always be eager to embrace those tools that have been shown to have value, but we cannot be defined by the tools. And often as young doctors, we get so excited about learning to use a new tool that we think that that's what it is to be a doctor. Well, let me ask you this. How many iron lung specialists did we need after polio vaccine? If you go to Japan today, the vast majority of endoscopy is done by paramedical people, not doctors, because they have such a high gastric cancer rate. So you use the tools as best you can, and you put as many of the tools in the primary care setting as you can, but you're not defined by the tool. You're defined by the relationship. And every time a patient comes to you, they seek relief from suffering, they seek information, advice, but mostly they seek hope. And we can never forget that. Whether you're dealing with the most critically ill, as this man in Uganda with HIV/AIDS, or this older woman in Argentina, we must leave every encounter with a patient giving them some hope. And even if they have a fatal illness and are about to die soon, the hope for them is the sense of meaning and purpose to their life. And that goes to our experience in healthcare, which should be one of joy. Because if it's not, you won't be doing as good a job as you could do. The top study is from 8,000 surgeons in the United States, and they used these scales of joy, what are called joy and meaning. And what they found was that for every point increase or higher score on an emotional exhaustion scale, which was rated from 0 to 54 points, for every point increase, you had a 5% increase in error by the surgeons. For every 1% increase in depersonalization, beginning to think of the patient as just somebody that's in your way, there was an 11% increase in reported error. And if you think this is just a bunch of crazy American surgeons, studies among British general practitioners show somewhere between 1/4 and 1/3 report burnout, and 1/2 to 2/3 are thinking about early retirement. So we can talk about money. Money's important. We can talk about resources. They're important too. We can talk about having adequate staff. That's important as well. But what's most important is the sense of purpose, the sense of meaning, the sense of commitment that we have to our patients. That's what will bring us the joy and meaning in our life. And it's been my great fortune to have met many, many family doctors around the world who demonstrate that commitment every day. When I visited with young family doctors here in Portugal several years ago, 3 years ago now, and I asked them about the difficult economic situation, the fact that their pay had been cut. I said, this must be terrible. And what this young woman said to me was, well, it's much worse for my patients. I'll get by. You have people like Dr. Belém Rodriguez from Paraguay, who works with Médecins Sans Frontières in Sudan and Somalia and Yemen, going to the most dangerous places on earth and doing her best to help relieve suffering there. And then you have people like Dr. Kobranoff, Dr. K I call him. He earns $25 per month, often has to reach into his pocket to give the patient money to go buy the prescription that he's written, and he loves what he does. He loves what he does. He's the most enthusiastic person you could imagine, and his patients love him for it. This was one person that taught me a great deal about what it meant to be a family doctor, Barbara Starfield. In fact, the story I like to tell about when I first met Barbara was in 1999 when I was elected president of the American Academy. I was in Florida, that was our meeting. It was midnight. I'd had a very long day after the election. I was exhausted. I just wanted to go to sleep, and the telephone rang. And it was Barbara calling, because where she was in California, it was 9 o'clock. And she said, hello, Dr. Roberts. Yes, this is Professor Barbara Starfield. Congratulations on your victory. Do you have a few minutes so I can tell you everything that is wrong about family medicine? And I looked at the phone. There was a part of me saying, like, who the hell are you to tell me about it? You know, she was a pediatrician that became a health services researcher at Johns Hopkins, which has no primary care to speak of. But you know what? I was smart enough to listen, and she taught me what was wrong about family medicine. It was that we were losing sight of what she saw as the two key aims and contributions that we make, which I'll come to in a moment. But Barbara's influence has stretched around the world, as this Unidade in Brazil shows you. This is the Barbara Starfield Clinic, and she would be very proud. And what Barbara taught me was that the two key aims and assets of family medicine are continuity, having that ongoing relationship, and comprehensiveness of services. She'd like to say, if I could figure out how to get family doctors doing brain surgery in their practices, the patients would do better, because it would be appropriate and it wouldn't be unnecessary. In my own country, almost 2/3, 2 out of 3, cardiac catheterizations are unnecessary by cardiology's own criteria. On continuity, the thing I would say, especially to my younger colleagues, is this. Early in your career, you're going to want to move around and experience different kinds of practices, and that's just fine. But don't for a minute think that you truly understand the joy and meaning of being a family doctor until you've been somewhere for a while, because family doctoring is about person and place. It took me about 10 to 15 years before I began to realize the power of that relationship and appreciate the joy of it. The times when patients would comfort me for my mistake, which I had admitted to them of one sort or another. I was just hoping that my rate or probability of error was not 1 per day, but that's another story. And as to comprehensiveness, the other thing you should be asking yourself, in addition to the question of how well is my relationship going with my patients, you should also ask, how can I do more for them? I love the quaternary prevention movement that's kind of erupted out of Europe, which is designed to keep people out of the hands of specialists. Now, I don't have any problems with specialists. There are a lot of nice people out there that do other kinds of medicine, and they're very important when I need them. It's just that I need them much less often than they think I do. And I want you to take more of that care on. So when you talk about continuity, here are two brothers in Mumbai, India, that have been in practice together for 45 years. And one's an Ayurvedic physician, the other is a Western medicine physician, and their business card has one person's name on each side. And their father was in the same practice for 50 years in the same building. So that's almost a century of this family providing care to this community. Skill. We get very worried when we're trainees about keeping the person with status asthmaticus alive through the night. And you need skill for that. But remember, the real skill of family medicine is being able to take the evidence, which is actually the easy thing to go find, understanding the context, who is this person, what is the setting that we're in, and then understanding their values, what is it that they really want, and putting that all together in the clinical decision. That is the true skill of the family physician, and it's very challenging. Some of you have seen this. Don't shout it out if you have. But one of the things that I like to use these next several slides for is to remind me of how we think as human beings and as doctors. We think in patterns. We're eager to reach out and see a pattern in something so that we can put our arms around it and say, I know it now. Now I know this. I'm confident. So if you don't know what this is, what you'll try to do is you'll break it down into basic patterns. And you'll begin to modify the pattern and look at it from slightly different direction and see them in new situations. And now the only thing you can see is the cow. You get this pattern. You know cows. You understand cows in every way, shape, and form, don't you? Well, think again. Because the challenge in our work is you may see 15 people with the same upper respiratory symptoms in a day, and then the 16th person is the one that's got active pulmonary tuberculosis and not some viral syndrome. That's our challenge as family doctors. So I'm going to finish with one word. One. I think the one thing we need to do as a discipline is figure out how to standardize customization. The specialists want to standardize standardization. We need to standardize customization to make each person feel special and to have each decision unique to them. And I think we can do this. But to do this, we need way better science. We need way better tools that help us support our decision-making, clinical decision-making. But it's possible. Think about buying things. Imagine Amazon.com. They know what I want even before I log in my password, for God's sakes. So this can happen. We just have to think creatively. And I think it's going to be the younger doctors that will help us begin to do this. But the other one word I want to share with you is this image. It's the image of a single nun going to the slums of Calcutta, reminding the world of the suffering of the poor. It's the image of one man with a shopping bag standing in Tiananmen Square 25 years ago last month, stopping an entire column of tanks. It's the image of one man, a president in South Africa, showing the world what forgiveness means. There's power in one. I think that each of you, as a family doctor, has the potential to be that one. Because when you help one person, it means you help one family. And when you help one family, you help one community. And when you help one community, you help one country. And when you help one country, you help the one world. I think you are that one. And when you get into trouble or you need help, turn to another one. Reach out to your colleagues. Support each other. What we do is difficult work. And if they're too busy or cannot come, then you call me, and I'll do my best to help.